you. February is the month of love. And here we are, all people who love each other, with an academic feast, which is also what we all love. So today we are having two very good lectures and very special guests today. But before I go on to that, and before I let Dr. Uma take over, I'm going to welcome our two guests of honor today. Dr. Sharda Jain, first of all. I can't call her a guest of honor. She is, like we were just discussing, our entity and someone we all look up to. So just a brief biodata, Malti, if you can share with me. I know Madam doesn't like us to share her CV, but Malti, if I can have the CV. So Madam is the Director of Life Care Center and Life Care IVF. She is a faculty for 2 decades from PGI Chandigarh. Madam is Secretary General, founding secretary, founding team of Delhi Gynae Forum. She is a member and expert observing the Ethical Committee of NCI 2018-20 and again in the National Medical Council from 2021 to 23. She has been decorated by, I would say, many lifetime and many achievement awards and living legend awards by many prestigious bodies. Her passion is teaching, hand-holding, safety of doctors, and creating medical legal awareness. I would request Dr. Sharda Jain, Madam, to say a few words before we start the academic session.
It's an awesome moment for me to welcome the presidential candidate for Foxy. We all know it's a very dear body to us, and a person who heads is also very, very dear to us. Dr. Sadhna, the other day I was talking in Jaideep's meeting that anybody who says that I am a presidential candidate, the 50% job is done. The day you say that you are a presidential candidate, we start saluting you. Rest 50% job is very easy. You request those for whom you have worked. And the people whom you work, they will definitely vote for you. Hindustan ki janta unko kabhi nahi bhulti jo unke liye kaam karte. So this is what all things are about. And I think you've done a very hard work. Coming to a presidential post itself is a hard work, it shows. And I think, things become very, very clear to you now. I can see that, you need to be focused once you get this particular position, because your energy should definitely drive people that whatever resources are available for the country, you will definitely take care of them. So I have only one rule, 80-20. We have taken, as far as the maternal mortality is concerned, Foxy has done a great job along with the government of India, that our maternal mortality has come down tremendously. I think you need to be focused on that particular aspect. Jobs become very, very simple for you. And the topic which you have chosen today, I remember when I was doing my post-graduation, cesarean section rate at PGI Chandigarh was only 5%. 2017 data shows of national figures that it is 17%, and in 22 start, probably we can say it is 20%. But I think the topic which you have chosen is definitely, you already said it's a bread and butter for us, and it brings a bouquet of flowers for us. At the same time, it brings bricks to us. But I think your presentation today will definitely see that Dr. Sadhna Gupta gets a lot of bouquet from you. So with these particular words, I will request my AOGD chief, Dr. Achla, to say good words for you.
Good evening.
Ma'am, aapka bhi intro ki slide hum 1 minute. It is my pleasure and honor to welcome Professor Achla Batra. She is our AOGD head. She is the president of AOGD. She is Professor, Department of Obs and Gynae at VMMC and Safdarjung Hospital. She is a highly decorated person. She has been the president of NACHI Delhi chapter 2018-2020. Chairperson of the Urogynecological Committee of AOGD prior to that. chairperson of the Rural Health Committee, OGD, prior to that. And she has been the honorary secretary in the past leadership at Subsidiary Hospital of AOGD in 2015-16. She's been ex-editor of AOGD, ex-editor Narchi, and coordinator for the Foxy Critical Care Conference in 2016 and the Yuva Foxy North Zone 2018. Welcome, ma'am, to today's CME, and I would request you to say a few words before we start the academic session.
Thank you, Meenakshi. Thank you for the kind words and good evening, everyone. Dr. Sharda Jain has already said a lot about the presidential election, so I just ditto her words. And regarding cesarean section, which is increasing so much that we need to not only know the technique properly, the post-op care, because the problems also occur in the post-op period. So that both the topics today are very good. And Dr. Sadhna, she is a practical person and she is deeply into obstetrics. I've heard her before also. So you're all really going to learn a lot and enjoy listening to her regarding the post-op care in the cesarean. And Rekha Bharti, very, very energetic young professor from Safdarjung who is very academic and very, very dedicated. You will also enjoy listening to her. So I think today's talks and the speakers, they are really fantastic, both of them. So this webinar, everybody is going to enjoy and learn a lot.
Thank you so much, Dr. Sharda Jain and Dr. Achla Batra, for the kind words. I would now request Dr. Uma Vaidyanathan to take over the rest of the session.
Thank you very much, Dr. Meenakshi. I would like to start by introducing the chairpersons for our first session, starting with Dr. Malvika Sabharwal. She's been conferred the Padma Shri by the President of India. Madam is the Chief Department of Gynae and Obs at Jeevan Mala and Apollo Spectra Hospitals. She is also the current President of the DGF Forum Central and founder chairperson of IAG Delhi chapter. She's been the past President, Delhi Gynecologist Endoscopic Society. Welcome, Madam, to today's session. Our next chairperson for the meeting today is Dr. Abha Sood. Madam is the Head of Department OBGYN and IVF, Jaipur Golden Hospital. She's the current President of DGF Northwest. She's a DNB's trainee with special interest in endoscopic surgeries, infertility, and endocrinology. Our next chairperson for the session is Dr. Kishore Rajurkar. Sir needs no introduction. Sir is a senior consultant, gynae and perinatologist. He's the head of department of Obs and Gynae at Sanjay Gandhi Memorial Hospital. He's a current president of DGF Outer Delhi, winner of several laurels, has contributed many papers in AICOG and FIGO. He's a current COVID consultant and HIV consultant. Welcome, sir, to today's meeting. I would request Dr. Malvika Sabharwal to introduce our very esteemed chief guest for the day. Thank you. Dr. Malvika? I guess she is not there. Dr. Malvika? Dr. Kishore, can you please do the honors for us? Dr. Kishore? Yeah. Sir, can you please introduce our speaker?
I have to introduce
Dr. Sadhna, yes.
Dr. Sadhna. This is actually, okay. I am honored that because Dr. Malvika was not there, so I have been asked to introduce Dr. Sadhna. And Dr. Sadhna, she's a Foxy representative at SAFOC from 2018 to 2021. And she is also the ICOG Governing Council member from 2015 to 2021, awardee of Best ICOG Governing Council member. And she has been, I think, in academic for a long time. And her academic career includes a medal for the best MBBS student, the 9 gold medals in MBBS, and just it goes on. So she has been academically very, very good. And after that, she has been contributing in all the conferences, in lectures. She's also a coordinator. And I think a very important topic of a cesarean section has been selected by the DGF. And it is going to help all of us in knowing more about the cesarean section, the practical aspects, and also how to deal with the complications and like that. And recently we have started a cesarean audit by the government of India, and I was also the member secretary for that. So I think it is going to affect that also, and we will have a very beneficial effect of this particular lecture. So Dr. Sadhna, please.
Thank you. My all regards to first of all, a hearty thanks to DGF for giving me this very, very important and wonderful opportunity to be sharing the dynamics and the dynamism of leaders and everybody. And this is thank you, and we are blessed to have the blessing of leaders like Dr. Sharda Jain. And my regards to my chairperson, Dr. Kishore and Dr. Malvika. So today we are talking about cesarean, and we have taken a little different, right, from different techniques, what we say unpredictable situation. We are focusing today in next 20 to 25 minutes that does post-cesarean care differ from routine surgery, and what sort of complication from all over the organ we can have in post-operative period. So be aware and be aware, and I bring greeting from ICOG, CEFOG, Journal, all the wings of FOXY, which I have served lifelong in various capacities with dedication, with excellence, and with all the selflessness what Dr. Sharda Jain was talking about. Delhi is a very, very, it is something what we are today, we are like, it is the long destined relationship. Dr. Alka Kriplani was my vice president when I was vice president. We had a long relationship with all the dignitaries, all the members of Delhi Obs-Gynae Society. And today it is my pride, privilege that I am with you all, as Delhi is a heart and head of our country. And Delhi is the place where all the problems are faced and the solutions are made. So my all pranam to mentors, teachers who are there and who are with us and in the Delhi. So cesarean surgery, it is a surgery or it is an alternate mode of delivery. It is unique because it is always having two lives. Only surgery when a live being is produced, done in wide range of setting, most inexperienced horse surgeon, in PHCs, in small nursing home. It is done by variation in expertise and experienced professional, done for limitless indication, and it is done 24/7, anytime, anywhere, anyone. And thus it brings bouquet and brings both to us. So it has been always a controversial operation, and it has status has been changed from a life-saving disparate measure to make a convenient and social reason as an indication for cesarean section. But we tend to, when we do in and out cesarean every time, we tend to forget sometimes that it is also a major surgery and has all its inherent risk. And when there is we consider that it is very safe. What is it? Most junior anesthetist is sent. House surgeon can do it. Resident one can do it. But we tend to forget that the margin of safety and unsafety is very less. And now there is a lot of controversy that the private sector is doing more cesarean section, and always there is a media hype, and still the cesarean section rate is not that high in India. It is around 20%. But of course, in teaching institution, tertiary or private sector, the incidence is little high. So,
Ma'am, I would like to interrupt. Your slides are not moving.
Greetings from all, and it is all my Delhi's memoir that I was saying that I am this time that we have a very, very long and in close relationship with the mentors and leaders and all the members of Delhi Obs-Gynae Society, and it is a cesarean section which is unique. Am I audible now? I'm audible?
Yes, ma'am.
And the slides are moving also.
Yes, yes.
So cesarean is a unique because it is done in various settings, and we are really have that like some question mark that why we are doing so much of cesarean section, and a lot of medical legal issue what madam was taking is it is much more related in a quite number of cases with cesarean section. So the all professional body has got their changing statement with the changing time. So it was initial 15%. There is no increase in maternal perinatal morbidity beyond 15%, but WHO has taken a back stand and says that every effort should be made to provide cesarean section. Any woman who is in need, and there is nothing that we are striving to achieve a specific rate. Foxy also says that every woman has the right and expectation for having a successful and safe delivery. It may be vaginal route or it may be cesarean route, and every patient should have a right to safe cesarean section whenever it is needed. A little bit that the all cesarean are indicated, unnecessary, unindicated, less indicated. There is a lot of issue. People are changing, our setups are changing, people's expectation is changing, and we have to always consider that it is a judicious cesarean section or not. Why it is a hazard of high cesarean section rate? We are all having backlash of the high cesarean with the placenta accreta spectrum. And again, we cannot provide the safe cesarean section for that 27 million delivery in a very large number of patients. So it must be a little bit balanced indication, and we are having that backlash of the cesarean complication. So one message this is that it should always be a just cesarean section and not it is just a cesarean section, it is nothing in it. Because the estimated risk of women dying after cesarean birth is 0.53 per thousand, but with vaginal birth is 0.04. So still the safety of cesarean section is quite low, and the risk of criticality as well as mortality is 3 to 4 times higher than vaginal birth. So these are the thing which is the topic of today, that these are all new paper. It is all 2016 to 2020 paper, which shows that the tertiary care centers are having so many referrals and for the complications after cesarean section for many causes and diverse range of complication. So with cesarean section has done, but in post-operative period, immediate post-operative period and a late post-operative period, patient carries legacy of antepartum profile. The things are not lost with the delivery of the baby. Signature of skill and expertise of surgeon, and also memory of compassionate yet vigilant doctor and team in post-operative period. And I will focus for the third part today. So we need a continuum of care right from antenatal period to post-operative period, and which patient have got what complication, it depends upon indication, antenatal profile, surgical experience, and post-operative recovery, vigilance and alertness. So nothing is routine. Every moment is special, and that stands due for the post-operative care in cesarean section. So after all surgery, we have the monitoring, vital monitoring, fluid, antibiotic, analgesia. But cesarean is different from other surgeries because there is an issue of ambulation, oxytocic agent, exercises, thromboprophylaxis, breastfeeding, care of newborn, and psychological and emotional supportive care. And we have to be very sensitive to this difference, which is like different approach from the other surgery, what we do for other diseases. So it is the ERAS. This is the very good recommendation that the essential recovery after surgery, that there should be 1-to-1 observation, good monitoring of all vitals, urine output, and that is one point. Half-hourly observation should be performed for 2 hours, And then hourly if woman is stable, and see for bleeding and the lochia pattern, and again the COVID precaution in today's time. So this is IRA's recommendation, and these are very good, which prefer non-steroid and anti-inflammatory analgesia as compared to opioid analgesia, oxytocin agent, and we have now a very, very good drug carbetocin, which has actually added to good post-operative care, because now we don't have to use 8 hours or 12 hours oxytocin infusion with all its associated complication like fluid, like a antidiuretic activity, less, and the pulmonary edema or the heart-related tissue because of the over-infusion. So carbetocin, single-acting, long-acting insulin, and that has made a real impact on the post-operative recovery. Antibiotic single shot, which is doing, but always individualized as per case of the antenatal profile, early oral sips and nausea and vomiting, glucose monitoring, and the mechanical thromboprophylaxis for all, and pharmaceutical thromboprophylaxis when it is there as risk factor. So these are the basic, which is the routine care after cesarean section, and we have to be very, very sensitive to these simple things in our all cases. Now coming to aftercare, which is special in post-cesarean, let us come to the complication, and today I will discuss around 9 to 10 cases. All cases are real, either faced by me, my panel, my moderator, I have been called for see certain patient, and it is not only the obstetrical complication we have. Any system can have the present with the complication in the post-operative period. So this is very important, and that's why we should not only concern on the uterine involution or the lochia, but we have to see for the cardiorespiratory thing, for sepsis, for neurological, any pre-existing morbidity, psychological, and of course sometimes late complication. So I'm sharing few cases so that we are sensitive that it is not a something theoretical or something. A patient who has got like a routine cesarean section, what is shared in emergency cesarean section for the previous elective cesarean section, hypothyroid, and has on the second day mild distension, bowel sounds are reduced, and we know it is a paralytic ileus, and it is a common thing, but there can be much serious thing about it. Whenever there is a paralytic ileus or symptom like paralytic ileus, we have to consider many things, that is sepsis, electrolyte imbalance, and if the patient is not like having also sometimes the forgotten some mop or foreign body, if their symptoms are like that, and again opioid analgesic should be avoided. Early chewing gum or oral sips are good, but if it is a frank paralytic ileus, then we have to come for all the measurement like nasogastric tube aspiration, keeping patient neurally, and or electrolyte imbalance. So whenever there is a bowel symptom, patient is having a little distension, not able to pass flatus, you have to consider all the things which may be trivial to something serious. Adhesion, sepsis, any uninverted, unrecognized bowel injury, if there is fibroid degeneration, and a word about Augie-Levy syndrome, which can be life-threatening. So sepsis, when you think patient has chorioamnitis, patient has been handled, patient has been referred to you, always think for sepsis and work as a surviving sepsis campaign. That is the 1 hour sepsis care bundle with all antibiotic, sending blood culture and measuring rectal. So when you do the X-ray, we did the X-ray, this was a abdomen colonic dilatation, and this is a rare entity, but whenever it is, it can be very serious and life-threatening, and there can be bowel obstruction without any mechanical obstruction. And why it happens? It is happening because there is a damage to parasympathetic nerve supply that run close to cervix, vagina, and broad ligament. So whenever there is a cesarean section, you have a difficulty, especially in second stage or in a second or third cesarean section. Be there if the patient is not improving with the normal, like a conventional treatment for paralytic ileus, we must be aware of this entity, and it leads to cecal ischemia, perforation, and peritonitis. And the rapid decompression is indicated. Sometimes neostigmine helps and sometimes you have to do the laparotomy. So this entity is there, which is specifically associated with cesarean section, and this is a patient who had the cecal ischemia perforation and had landed upon the all iliotransverse anastomosis. So beware and be aware. Post-cesarean PPH is a nightmare. We do cesarean section so that like sometimes we are okay and the things has been done. But if there is a PPH and cesarean section, the combination, the combo is sometimes monstrous. So these are the common case situation. Twin pregnancy, patient for the hypertension, she is on the nifedipine, she is on the Maxer, and all drug cause relaxation of the uterus, atony of the uterus. And this is the same very, very common situation. Patient had twin pregnancy, all risk factor, and after 2 hours, she had atonic postpartum hemorrhage. What our system needs, it is the like all the things what is done in the PPH, any case, any time. But after cesarean, because she has done surgery, the patient attendant is panic. You are also very much stressed. So availability of all emergency drugs, taking a lead by obstetrician, doing all good hemogram, coagulation profile, directed blood component, and calling of friends like anesthetists, intensivist, and all facility to quick exploration of genital tract. So this is very common, and in every high risk case, we should be very, very careful that oxytocin drugs are not discontinued. They are having, nurses are having watch on the uterine tone. They are regularly checking their pads that the patient is bleeding or not, and they are very, very careful about vitals. So we know as an expert, but it is the team, it is the nurses who are doing this post-operative care, and they should be very, very trained, and they should be very, very sensitized about it. This is a very good paper which shows that the elective cesarean section and the second stage cesarean section have highest risk for the postpartum hemorrhage, and both have different issues like general anesthesia, placenta previa, which cause in elective cesarean section severe PPH, while in intrapartum cesarean section, that is a choriamnitis, induction of labor. So all, and the carbitocin, I would like to say one word, that the carbitocin actually have a greater affinity for oxytocin receptor. And in elective cesarean section, there is actually no endogenous oxytocin. So for elective cesarean section, we have more chances of having severe PPH or moderate to severe, and carbitocin is a very good drug because it binds very, very strongly to oxytocin receptor. So it is a double complexity, and it is the time like we, our nurses and everybody should be attentive to it. From revealed to concealed hemorrhage. Concealed enemy is very, very difficult to fight because when the patient is unstable, you never know actually what is happening. There can be medical issue, there can be drug-related issue, but we have to be very, very aware of all concealed bleeding. There can be broad ligament hematoma, and it can be retroperitoneal hematoma, and sometimes if the patient is second stage, you can have even vulvar hematoma. So very, very good examination. Sometimes we can treat it conservatively, and sometimes we have to go for the extreme measure like the relaparotomy or the radiological embolization. So I will give, there can be inferior epigastric vessel rupture, rectus sheath hematoma, and a word about retroperitoneal hematoma. They are very uncommon. But when they are there, it has been related to maternal mortality as well as critical morbidity. So a word that we should be aware that cervical tears, injury of uterine and ovarian vessel during surgery, patient who are having HELLP, patient who are having the jaundice, they can have retroperitoneal hematoma even with the straight surgery, simple surgery. And we should be aware that these are the symptoms. The classical sign which our young generation is actually forgetting, that you are seeing bruise, you may think of DIC, but it can be the retroperitoneal hematoma also, that it is a bruising around umbilicus and bruising around the flanks. So the awareness of the possibility that it can happen, it is a life-threatening complication. The women today are so much on aspirin, so much on heparin, so much on anticoagulant. And these are the patients who can have this sort of hematoma, broad ligament, retroperitoneal, and the concealed hematoma. And in those cases, we have to do CT, sometimes CT angiography, and ultrasound, of course, is a first line investigation. So keep the diagnosis of common thing, and sometimes you face the uncommon thing, and these are around 21 cases, and in every case they have tried the different thing. Relaparotomy, we think it is a loss of face, and it comes with a medical legal issue, so many questions. But relaparotomy can be a life-saving measure for a near miss fatality of the mother. And internal hemorrhage is one of the very, very dicey situation when we have to do early relaparotomy and the timely relaparotomy. But always take all informed consent, document what you are doing, and always invite and take opinion of 2 or 3 doctors, maybe from different specialty. So relaparotomy is the issue, and it is all 2018 and 20 papers from tertiary care hospital, which shows it is around 1.04 per 1,000 relaparotomy incidence after cesarean section. If it is needed, don't delay it, and do it properly with all your friends, good intensivities, good anesthetics, and a good blood component therapy. And be thorough in exploration, because there is no excuse for third laparotomy. We know, so whenever we do and we don't find anything, we have to be very, very thorough in all the examination. I still remember one relaparotomy in which we missed the perforated appendix because it was swollen and pus, and it was surrounded by adhesion. So we have to be very, very thorough in relaparotomy. So these are papers that it is not uncommon. It is a life-saving operation, and it again brings us bouquet and the bricks. So it is something which we actually fear, but we have to dare. So this is again a 4th case situation, which shows the patient was severe PIH and she was fine. She was done cesarean section, and after 36 hours, patient had suddenly ARDS, blood pressure 200/110 millimeter Hg, oxygen saturation low, chest congested. Why it is important? Because when we say the patient that you do cesarean section, now we are having a quite low threshold for the preeclampsia doing cesarean section, and we say when the baby will be delivered, the things will be fine. But we have to pre-counsel that the things can be anyway. You can have the blood pressure in post-operative period. Maybe you may need the antihypertensive for the long time, and that pre-cesarean or pre-delivery counseling is very, very important. So hypertensive emergency, it can go anywhere. ARDS, heart failure, stroke, myocardial infarction, and we must be ready with all labetalol, hydrolazine, everything. And this is very important, that whenever there is a hypertensive emergency, and what obstetrician are used to these 3 drugs, labetalol, hydrolazine, and nifedipine. But the hypertensive crisis is not getting corrected, or blood pressure is not under control, then it is better to shift to ICU, because they can have the other with the intensivist, so they can do all the necessary measures like nitroprusside or other drugs. So this is very, very important message I want to give, that the postpartum hypertension can be new onset, it can be de novo, and it can be manifestation of severe preeclampsia. So be aware that the persistent hypertension postpartum can be life-threatening. It needs urgent correction, and it needs careful follow-up that the blood pressure is fine or not. And what I say, that it is always better to take the opinion of intensivist and the multidisciplinary team. Maxsurf is not an antihypertensive agent. We all know as an august audience, but it is a choice for the seizure prophylaxis as well. It is a case situation 5. Patient has been done the cesarean section for 2nd stage arrest. It was okay, done in midnight, but in the morning she present with abdominal pain, fever, flank pain, hematuria, weak urinary system. So when you used to give oxytocin for a long time, it is a common problem that the patient is having only 100 ml of urine and it is colored. But always be aware that the urological injury are again not common, and in primary cesarean 0.2%, repeat cesarean 0.6%. Clear signs, we have to retain our clinical acumenship. and that is fever, pain, distension, retroperitoneal urinema, sometimes urine leaking from vagina and brain side, and most common, bladder is the most frequently injured organ. And when you think that we have missed something, urinary tract injury, we have to do all the investigation, take the opinion of urologist and renal ultrasound, and do the timely intervention with all the procedure what urologists have. So be aware and be aware again, and learn also technique to recognize urological injury at operation table, and also learn to repair the simple bladder injury, which then the difficult injury. So this is very, very important. And never what we say, if we have done something, don't share it. What Dr. Sharda Jain says very, very rightly, that speak up. It is surgery, it is obstetrics. We are going to have complication. It is nothing to be ashamed. We have variable level of expertise, variable level of our own health, our own moods. So don't be afraid of it, but be careful that we can have cesarean bladder injury, which is very, very common. And what is the learned art of, first of all, preventing urological injury in every cesarean section, and if it has been done, recognize at time of operation table. But if it has been missed, then timely consultation and timely referral. It is again a 6th case, and the patient comes with she has the emergency cesarean section for transverse lie, and after 30 minutes again ARDS. And now today with the ARDS in COVID era, we are so much COVID minded that we say a patient might be COVID positive even if the test is negative. But we have a lot of issue when the patient can have ARDS in post-operative period after cesarean section, and this patient has very low oxygen saturation. Suddenly everything was changed with the simple cesarean for transverse lie, and suddenly everything, like all intensive, it is high ICU, and what the patient, we should have all ARDS, that all differential diagnosis from pulmonary edema, heart failure, cardiomyopathy, myocardial infarction, embolism, sepsis, COVID related, as well as the drug toxicity. So it is the finding, it will the sign of cardiologist, but our work is to take opinion, and whenever the patient having the symptom of dyspnea, chest pain, fatigue, palpitation, peripheral edema in antenatal period in last month, you can consult, you can do advise echo and the cardiologist consultation, because nowadays we have a lot of patients with the risk factor for peripartum cardiomyopathy, multi-fetal pregnancy, hypertension, extreme of maternal age, patient on the very high risk pregnancy, prolonged use of tocolysis, and it is a timely diagnosis and timely thought of the thing that peripartum cardiomyopathy is there, and then we can take echocardiography and the cardiologist consultation, and these are hypokinesia, dilated left ventricle, and as in India, for a first line treatment, first of all, we are only there after cesarean section, so we must know that much of knowledge that treatment of heart failure, that is diuretic, vasodilator, bromocriptine is also a modality of treatment in peripartum cardiomyopathy, and again all follow up that the patient should avoid pregnancy. A 7th case, this patient, she has come with the obstructed labor. This I have said, it was a referred case done at 11 p.m. and I was quite okay, that patient has done. And after that, patient suddenly have the blood pressure 80, pulse steady, disturbed respiration, confused look. And as an obstetrician, when this thing happened, we also always think that it is hemorrhage. And I was really very, very troubled. So did everything, but it was blood pressure 70, 80. She was not comfortable. And we did the blood sugar level, which was very high. Patient was 4th gravida, and when we started treating with normal saline insulin, diabetic ketoacidosis, within 2 hours, patient made a good recovery. So my takeaway is not like knowing first thing that these things can happen, and secondly, in India, we have to do multitasking, and that's why we must have the basic first line treatment. When the blood sugar is high, there are symptoms of, and the investigation suggestive of diabetic ketoacidosis, what we should do. So that is normal saline, that is insulin, that is a vigorous replacement and correction of electrolyte imbalance, and then again the multidisciplinary approach. So value of experience is not seeing much, but it is seeing wisely. And I think William Osler have said everything what could be said about a compassionate and a wise medicine. And neurological complication, these are the good papers from anesthetist journal that the patient can have sudden seizure after the regional anesthesia. Not because of eclampsia, not because of epilepsy, but it can be like a natural, what we can say, adverse effect or side effect of the regional anesthesia. These are the two patients. Actually, I remember it. The girl, the second patient girl was poliomyelitis. She had a normal conception. I was very happy and did cesarean section because of hypertension as well. And only one reading of 160/90, and after 1 hour, patient was not speaking. She was responding only by finger movement. All vitals were okay, and I took 4 to 6 hours. What is happening to this? And everybody was troubled. And we did MRI, and it was quite a large subarachnoid hemorrhage. So patient on sometime aspirin, patient sometime even a single reading can cause the neurological complication, and any neurological issue should be taken very, very meticulously, very, very in a coordinated way. So we can have neurological complication, hypertensive complication, post-anesthetic, pre-existing neurological problem. Sometimes patient doesn't tell that she had sometime epilepsy and she has left anticonvulsant drug. In today, our scenario, sometimes it is like it is a quite not that uncommon, and we always do the all neurological examination. So headache, we know always there is a headache. We see it is a post because it is a regional anesthesia, but always consider all the differential diagnosis. This is my takeaway, that don't think that it is only the postdural puncture headache which we treat by a good fluid, lying down, the limitation of movement. And the management option, we know posture, hydration, and paracetamol. So consider these are the all cases which we feel, and suddenly actually after cesarean, when there is a baby is born and happiness, and their issues comes, and it becomes quite sometimes very difficult to make the attendant understand that things are being changed, and she has to take neurological opinion. So very, very important that we can have seizure, we can have subdural hematoma after spinal anesthesia, we can have severe headache, sometimes which is not responding to the common treatment. Thromboembolism is a thing much more in the like where the high socioeconomic class, patient on drug, obesity, and it is a like a cause of sometime a sudden maternal complication and sometimes fatality. So intermittent, what is mechanical thromboprophylaxis for all, and heparin in high-risk women. So a word about it, that it is not a routine use of heparin which is recommended. And if there is a one major risk factor or two minor risk factor, then heparin prophylaxis as a thromboprophylaxis is indicated. And those is also depend upon the risk factor. You can give 40 or 60 according to weight, and if it is very, very high risk, then you give the total dose. So a word about it, because heparin always in the post-operative period, that can lead to what we say hematoma, sometimes postpartum hemorrhage, though the research says that it is not related to it. But in our all obstetrical setting, we always become careful for it. But we have to select who are the risk patients who want the pharmacological prophylaxis and mechanical prophylaxis like early ambulation and the leg exercise. This should be the protocol for all cesarean section. I will come in next 2 or 3 minutes. Again, patient has been discharged. Is the thing over? Life is not over. And this patient can come on the 7th day with the wound infection. And wound infection, again, the surgical site infection, it is a sore. Patient is so much worried. It becomes chronic. Dressing, antibiotic, and everything it goes. And the issue lies in the prevention. That is nutritional status, anemia, good surgical aseptic technique, that is very, very important. And sometimes this wound infection can be serious, leading to necrotizing fasciitis. And sometimes it is not the dressing and antibiotic, but we have to debride. We have to take sometimes general surgeon's opinion. So the prevention is the very, very important thing. But if the patient develops surgical site infection, it should be taken with the good care, with good culture, with good dressing, and whenever needed, you think that the surgical exploration. What is prevention? What is say? Nothing can be emphasized that we should be very, very, very particular about aseptic technique. Surgeons, it is our, what we can say, it is our surgeon's ornament. Surgeons should be meticulous. Even if reflexly they are very clean. They use do hand wash repeatedly and prophylactic antibiotic and the routine. Like if we say prophylactic antibiotic, if the patient having chorioamnitis, she has she has a diabetic or she is high risk case, you can suggest that you can give antibiotic for 4 to 5 days. Post-cesarean pyoperitonitis, again, what I say, perforated appendix, I missed it and the patient was totally in septic shock. So this is very important. It can come after 3 to 4 days as well. And pyoperitoneum when we need the drainage of the pus or we need the exploration. This is the last case which gave me a lot of trouble in railway hospital. She had the 2/3 cesarean section and patient came with the secondary postpartum hemorrhage after 10 days. Ultrasound normal limit, whenever we gave the IV fluid, blood transfusion, she became quite well. She responded well. She was discharged. But after 7 days, again she had the life-threatening bleeding. So it was a 3rd cesarean section, completed family. So we advised that better to do hysterectomy, but the patient took 3 or 4 opinion because she was some union leader in the railways. So everybody says, yes, it is okay, you are okay. But she came with the recurrent hemorrhage. In a once last hemorrhage she was pulseless, BP-less, and we did a quick hysterectomy and we found only priaval infected uterus. So ultrasound and imaging many times fail to give clue to cause of secondary PPH. This is very important because we cannot diagnose the scar dehiscence. So pseudoaneurysm is a one modality which we should be very careful. Patient comes suddenly, patient have a life-threatening severe hemorrhage, and if you give all the things, patient become okay. And again she had the recurrent bleeding. So this is very important that we are careful about it. We do color Doppler study. We take the good picture, and the modality of treatment is hysterectomy when there is instability. It is better to do hysterectomy, especially if the patient has completed family. And the second is the arterial embolization. So these are beautiful picture, yin and yang, that what color flow you get and how you should do ultrasound and imaging to confirm the diagnosis of pseudoaneurysm and the postpartum uterine dehiscence, which can also come as a secondary postpartum hemorrhage, and sometimes and many times need hysterectomy, though sometimes it can be taken conservatively with excision of uterine incision margin and repair. So life does not end here. Again, we say that there is a backlash of cesarean section, especially patient headache, neurological or any complication like PPH, like exploration. So more you did the exploration for PPH, there are more chances that patient has the secondary infertility, Asherman syndrome, placenta accreta syndrome, and the postpartum anemia. Cesarean section is considered an independent risk factor for postpartum anemia, which is now considered as important public health. So we are going for an anemia book for it. It is our mission. And high cesarean section rate and the associated pathologies and the complication can add to our issue because we get lost to there is no criteria that when the postpartum woman should come to our hospital again. So life continues in homes and roads and not in the hospital. And again, I will start in the end that even Robson's, which is given the good criteria for auditing the cesarean section indication, he also says that cesarean rate should no longer be thought of being too high or too low, but rather whether they are appropriate or not after taking into consideration all relevant information. So whenever there is surgery, complication comes like a gift with surgery, and we have to be very, very meticulous. So what is judicial? What is judicious? This is very, very important. Cesarean is always controversial from indication to postpartum care. But we have to be very, very stable, non-controversial, compassionate, alert, and vigilant doctor. Human birth always destined to fraught with dangers. Somehow people as well as obstetricians tend to forget this. Birth of child gives new birth to mother, It is not an old dictum, it is ever-trying truth. We wish that we all always become a vigilant and compassionate doctor and also develop a vigilant system. Thanks for active listening. So we are having on 14th of Valentine's Day. Life is also sweet and bitter like life. And what God has designed, so we don't understand fully, but there must be some secret behind it. For any post-cesarean complication, there is some secret behind it. And God wants us that we should search for His secret. And this is what the beauty of the medicine, what we take as a profession. So thank you for active listening, and everybody will remember how you treated when the person was in problem. And I seek your all both nomination, full-hearted support for my presidential candidature, so that we can do best for our fraternity and best for women of our country. Thank you very much.
Thank you so much, Dr. Sadhna. We'll never forget your words. It's not just a CS, it should be a just CS. I think that message really has stayed with each and every one of us. I would like to request Dr. Abha Sood to kindly put forward her.
Yes, thank you, Dr. Uma, giving me this opportunity. After such a wonderful lecture and the topic so nicely chosen, and there's nothing which I can add, but you know what I can say is the type of complication you have depicted. We have seen it when I was working in a public hospital, but as I started practicing in private setup, the things are not so bad. And why they are not so bad? Because what I observed was the complications which mostly occurred were in late first stage or second stage cesarean sections. And since we are senior persons working in private setup and we take decision little early, so now the government of India has put an audit on us, and they say we must fill in a column that should we have waited little longer. So I don't think that's the right. Dr. Rajurkar has also helped in drafting that particular form. So I am little, wondering, I fully agree with your last slide. We should not bother about what is the incidence, whether we have done at the right time for the right person. That should be the thing to say at last, because the complications can be due to pregnancy itself, the surgery itself, and there can be incidental causes also. So as you said, we have to be vigilant and take decision at the right time. This is what I want to say. Now let's hear Dr. Rajurkar.
So, your pulse. We are filling that form, the audit form.
I know. I think we'll talk later on about this audit thing. First, let us stick to the topic of today for cesarean section. So I have some comments to offer. As we all know that this is the commonest obstetrical operation, and it is also considered to be easiest major operation, but it is also the trickiest major operation. So anytime you can land in trouble, and big surgeons I've seen in trouble. And it is very, very important because it still contributes 65% of the maternal deaths. I mean, if you see the complications, just PPH or anything, then PPH maybe. So all these things are possible. And I think we should be thankful to Dr. Mundrokar, who invented this lower segment cesarean sections, because earlier classical cesarean sections were being done. And I think our residents are also there. So therefore, they should also know that Misgav Ladakh is the technique we are using. And most of them do not know that what incision we are doing for the skin. They always say fan steel. Nobody is doing fan steel. We are all doing Joel Cohen incision. So therefore, these basic things they should. And if you ask what is Misgav Ladakh, they don't know. It is not a name of a person. It is the name of an institution in Israel where Dr. Michael started, but he did not give his name, and he has given the Misgav. All these things are minor things, but I should know. And Dr. Sadhna, you have very nicely said about the early recovery after cesarean section, and that is very, very important. in that particular aspect, I just want to say that when you put a catheter, urinary catheter, please take it out after 6 hours. I do not keep it for 24 hours, 48. What I have seen, because I have been in this field for last so many years, 30, 35 years, I have seen lots of chronic renal failures coming after 10, 15 years. So, and the only thing they had the surgery was cesarean section, and when the urinary catheter was put. So it is hourly basis. Complication rate is hourly. If it is 48 hours, 72 hours, the complications are more. So this is my observation. And also, I also want to say, because complications can be very, very dangerous, and we can lose patients. So, but in all the cases, the patient gives you a warning. Therefore, always listen to the patient, what the patient is saying. Just do not go by the resident's findings or that monitor, which is there, it is showing pulse, BP, everything. अगर patient कह रहा है कि नहीं जी मेरे को तो बहुत ज़्यादा दर्द हो रहा है, तो you explore that. Just don't give this diclofenac sodium and this paracetamol injection. So the patient is very, very important what she is saying. And one more thing I just want to say, your retroperitoneal hemorrhage, you have said very, very important. And that can be detected only by monitoring. No, nothing else. Because PPH तो होगा नहीं, बाहर आएगा नहीं blood, और uterus contracted है, तो कुछ पता चलेगा नहीं. That in such patients, but the parameters will decrease, and therefore you should always think of retroperitoneal hemorrhage, which can be massive. Another thing, whenever you do a cesarean section, two things you should do before you give an incision on the uterus. Always see the round ligaments, so that if there is a dextro rotation, you have to please check that. So many times I have seen uterine kati hui hai. So one should always see the correct the dextro rotation and see the round ligament, and after cesarean see the ovaries after cesarean. So these two things I think all residents should see. And ambulation is very, very important. Government में बड़ी problem है, but I think private में you can, after 6 to 8 hours you should ambulate the patients, and उसको पानी पिलाओ 4 घंटे के बाद, because you all know that only the fasting is also not required more than 4 hours. And similarly, after that, before cesarean 4 hours, after cesarean 4 hours, 4 to 6 hours, that's all. So that thing I think we should. And one more thing, baby has to. It is not the complication of the mother. Oh, baby को भी देखो. And baby की bonding is very, very important. Immediately निकाल के one has to put on the breast of the mother. So that is a part of natural cesarean sections. But I think we should follow them. It is being followed at many hospitals. Not in we do it after 1 hour or so. But in RML, during the cesarean section, the baby is put on the निकालते उसको डाल देते हैं उसके ऊपर. So all these things I think we should, and also we should never forget any mop inside. So that is very important. The counting is very, very important. So these are certain points I wanted to say. Thank you very much.
May I just add one point regarding catheter, Dr.
हाँ, बोलिए, हाँ जी.
You know, I received my training at Calcutta Medical College and Hospital, and there we just used to put a rubber catheter in the bladder just before starting the cesarean, and we used to invert the gloves there. And as soon as the cesarean was finished, we used to invert the gloves and the catheter, and patient shifted to post-op, and we never had any UTI. And the chances of post-operative infection was very less.
And just one more practical point I want to. One more practical point about the baby.
Never ending, Dr. Kishore.
Sorry.